Hello and welcome back to my channel. I hope that everybody is doing well. I hope that you guys have had a good weekend. I know we're coming to an end. It is Sunday evening when I am recording this, so the weekend is coming to a close, but hopefully everyone had a good weekend. Hopefully you got to get out and enjoy some of the fall weather, although where I'm at right now it's been pretty rainy and gloomy, but winter is coming, and so hopefully you are still enjoying the weather while we can. Unless of course you're like somewhere where it's warm, and then in which case I'm a smidge jealous of you, but Michigan is not, and we are headed into winter, that is for sure. I love me the summer, I love me the fall. I am not a winter girl, but I will ride it out. Anyway, so for today's video, it is going to be an antibiotics part 2 video. It's a video that I wanted to make for a really long time, but I just haven't had the opportunity or haven't taken the time to do it. But my first antibiotic video was really popular, and I mean, for obvious reasons, it's a very heavily focused on topic on your board's exam. And so I do recommend that you feel confident and comfortable with antibiotics before going to take your certification exam, because it's definitely all over that test. If you saw my first video, it was heavily focused on drug classes, some mechanism of action. For this one, this is going to be solely focused on indications for antibiotic treatment, and then first line choices, some second line choices, if patient has allergies, that kind of thing. Definitely very relevant to what is on your board's exam, so it will be very useful to you. If you haven't seen my first antibiotic video, I do recommend that you watch that one first. It's a great foundation, and then jumping into this, it'll just make it a lot easier content to kind of follow along. If you haven't though, this will still be extremely useful to you because, like I said, antibiotics is definitely a hot topic for your boards. So before we dive into that, don't forget to go ahead and like the video, subscribe to the channel. It is a free way to support the channel and help me in making content like this for you guys. I appreciate the support. You know how much I love this community, so I'm thankful for you guys. I thank you for your support. And so without further delay, on to antibiotics part 2. Alright, so first up is ENT, or ears, nose, and throat, and an indication for antibiotics. So here we have ear infections, including both otitis externa and otitis media. Otitis externa is an ear infection of the external canal, and it's often caused by water in the ear, which of course creates this ideal environment for bacteria to grow. So cleaning out the external canal is going to be a great first step, and it's going to help promote healing for the patient. Antibiotics are indicated with this. Here are some examples. Polytrim, or the polymyxin B neomycin hydrocortisone, also referred to as Polytrim, is a good option if the tympanic membrane is not perforated, as it can be ototoxic. Another alternative is something like ofloxacin, which is not ototoxic, so that will be a safe option if your patient's tympanic membrane is indeed perforated. Also, it's important to educate your patient to keep the ear dry during treatment and to expect improvement in symptoms within 48 hours, though they may not have complete resolve for up to 6 days. And then also there's acute otitis media, which is an infection that occurs behind the eardrum, and this also requires antibiotics. This is treated with oral antibiotics as opposed to the otitis externa, which is treated with antibiotic ear drops. So with otitis media, you can consider a wait-and-see approach for up to 48 to 72 hours with specific patient population. In those patients who have AOM that is not severe, it's unilateral, not bilateral. In children older than 6 months, then you can try a wait-and-see approach before deciding if antibiotics are needed. So a bulging tympanic membrane, this is the most specific finding on physical exam that indicates an infection or an otitis media infection in your patient. Amoxicillin is the first line treatment choice, and the dosages are listed here. So it's 875 milligrams by mouth twice a day for 5 days for those patients above 2 months. For pediatric patients, you can do you should do the 45 mg per kg. Of course, it's going to be weight-based. You will never do, a pediatric population should never have a dose larger than the adult dose. So it's just important to note that if you start getting these outrageous numbers greater than the 875 that you're prescribing adults, then you would just stick with the 875 adult dose. You never would go higher than that adult dose. So also, if antibiotics have been used with this patient recently, or if they've had treatment failure with the amoxicillin, then you can try Augmentin, of course, which is the amoxicillin with clavulanate. If they have a severe penicillin allergy, then something like clindamycin or azithromycin are also alternatives for treatment as well. Next up is sinusitis. So generally this is viral and it doesn't require antibiotics, though patients definitely think that it does 100% of the time. Indications for when antibiotics are actually appropriate for this diagnosis are listed here. So that includes patients that have no symptom improvement after 10 days of symptoms and conservative management at home. High fever, purulent nasal discharge, or facial pain for greater than 3 to 4 days, and then symptoms, worsening symptoms following an upper respiratory infection that at one point seemed to be improving, and then the patient just began to decline again with their health. Amoxicillin, again, is first-line treatment choice. There are alternatives, though. Again, doxycycline is a great choice, although it's only appropriate for those patients greater than 8 years old. Pharyngitis, too, can be viral or bacterial, the most common organisms being streptococcus, gonorrhea, or diphtheria. So the majority of cases are viral and therefore they don't require antibiotic treatment. A strep swab or a throat culture, they can help you with diagnosing. Also, there's something called the modified Centaur criteria that helps you to distinguish when antibiotic use is indicated. This is specifically really helpful if your rapid strep test in the office comes back negative, but you plan on treating your patient anyways based on symptoms and exam. So this kind of helps you to figure out when these patients do require antibiotics. So tonsillar exudate is 1 point, tender anterior cervical lymphadenopathy 1 point, absence of cough, age greater than 3 years, both 1 point. Age 15 to 44, they get 0 points, and then actually greater than 45 years old, they take away a point. And then grading is as follows: 0 to 1 point on the grading system. Generally, antibiotics are not indicated. 2 to 3 points, you should consider testing the patient, and then 4 to 5 points, you should consider antibiotics. If you're treating with antibiotics, penicillin times 10, or I would say it in my mind, pen times 10. But penicillin 500 milligrams twice a day for 10 days is the first-line treatment. There are other options, of course, amoxicillin, and if the patient has a penicillin allergy, there's also clindamycin. And then, of course, again, with pediatric population, it's weight-based, so I included those as well. But this picture really gives you a good visual of viral pharyngitis versus the bacterial pharyngitis. So a corneal abrasion is a superficial scratch of the cornea, and it can occur from things like dust, dirt, sand, metal particles, contact lenses, and then other objects as well. So symptoms include pain, a gritty sensation in that affected eye, redness, excessive tearing, and then even blurred vision from this. So in office, with the use of tetracaine, which is like a numbing eye drop, fluorescein stain to stain the eye, and then a slit lamp, which is essentially like a black lamp or a black light, you will be able to diagnose these corneal abrasions. And there's a picture here that shows it really nicely. The fluorescein stain will congregate basically at the abrasion and will bright up just like that, make it really easy to see. So for those patients who are contact lens wearers, there is an extra concern for Pseudomonas infection, and so those patients should be treated and covered using a fluoroquinolone. For contact lens wearers, they should also be educated to discontinue the contact lens use during their treatment, and they need to follow up with ophthalmology, ideally within 24 hours of diagnosis, and this is to help prevent any further complications. And then here are listed some examples of antibiotics, both for the non-contact lens user and then also the contact lens user as well. Alright, so last up for ENT is going to be periorbital or preseptal cellulitis. It is referred to by both names. Common organisms that cause this infection include Staphylococcus, strep, and pneumoniae. Preseptal cellulitis, it's an infection of the soft tissue anterior to the orbital septum. And this picture here really shows the various types of infections, I think, really well. Generally, symptoms for this include unilateral eye pain, eyelid swelling, and then erythema. Indication for a CT of the orbits and the sinuses to rule out possible orbital cellulitis include inability to assess the patient's visual acuity due to such severe edema, bilateral periorbital edema, proptosis or bulging eyes, ophthalmoplegia, which is paralysis of the eye muscles, changes in visual acuity, or no improvement of symptoms after 24 hours of treatment. If any of these are present in this patient, then CT is definitely indicated. If it's determined that they can be treated outpatient safely, there are options for you. So clindamycin or Bactrim plus either Augmentin or Ceftonir are recommended treatments. The only GI infection that I'm going to talk about briefly today is going to be C. diff. C. diff is inflammation of the colon caused by the bacteria Clostridium difficile. If I said that correctly, hopefully I did. So it results in a disruption of the healthy bacteria in the colon, and it's generally due to antibiotic use. So discontinuation of the inciting antibiotic or the antibiotic that's causing this is first step, and then initiation of infection control. So this is going to be implementing contact precautions. This is imperative for preventing the spread of this, as it's very contagious. With patients who are stable and able to be managed outpatient, then it's actually treated with an antibiotic, the antibiotic being PO or oral vancomycin. All right, so on to genitourinary infections. First up being epididymitis. This is inflammation of the epididymis, and this picture really shows it well. So common organisms for this include gonorrhea, chlamydia, Pseudomonas, and then E. coli. The choice of antibiotic treatment is going to depend on whether or not a sexually transmitted infection is suspected. This can be determined, of course, by interviewing your patient, and you can also do STI testing as well. However, treatment should not be delayed pending those results. So choices of antibiotics for epididymitis that are caused by an STI include ceftriaxone IM plus either doxycycline. If they have a severe penicillin allergy, you can always do azithromycin as well. If an STI is not suspected, then levofloxacin is actually the first-line choice. Important to note that the most common causes of acute scrotal pain include epididymitis and then testicular torsion. So epididymitis, it really just needs to be high on your differential when treating those patients that are coming in with scrotal pain. All right, so next up is prostatitis. Common organisms for this infection include E. coli, gonorrhea, and chlamydia. Again, it's going to be important to try and determine whether or not this is related to a sexually transmitted infection. So symptoms of prostatitis include dysuria, dribbling, frequency, nocturia, hematuria, and then retention. If a sexually transmitted infection is not suspected, then this is going to be treated with ciprofloxacin, levofloxacin, or Bactrim are the options. And then if a sexually transmitted infection is suspected, then again it's that IM of ceftriaxone and doxycycline or ciprofloxacin. Syphilis is another sexually transmitted infection, and I feel like you're almost guaranteed to get at least one question like this or about this on your exam. It's described by its stages, including primary, secondary, latent, and tertiary. The primary stage involves the canker or sores or multiple sores, and the sore generally lasts for 3 to 6 weeks. It typically resolves regardless of treatment. The secondary stage involves a rash, and this can appear as the sore is beginning to heal or even several weeks later. And the rash can appear on one or more parts of the body, including the palms of the hands and the soles of the feet. Other symptoms include fever, lymphadenopathy, sore throat, and then fatigue. This too will resolve whether or not the patient is treated. The latent stage is when the patient has no symptoms of syphilis at all. However, the infection is remaining dormant for up to years. Finally, the tertiary stage, and this does not always occur, even if patient did not receive treatment. However, symptoms are severe, and those include organ failure and even death. Penicillin is the first-line treatment for syphilis, and there is limited data showing efficacy of any other antibiotic for syphilis. Also, when treating your patient, it's important to educate them on the Herxheimer reaction, which includes a transient fever, myalgias, and chills that occur within 24 hours of treatment initiation. All right, so next up for genitourinary is the treatment for a urinary tract infection. So common organisms for a UTI include E. coli and then Klebsiella. The general rule of thumb is to not treat asymptomatic bacteria unless your patient is pregnant. With your patients that are pregnant, if bacteria is in their urine, then we should treat them with antibiotics. And this is just to prevent further complications for mom and baby. So first-line treatment for pregnant patients for the bacteria and urinary tract infection includes, of course, the cephalexin. For nitrofurantoids, it's really important to avoid this in the first trimester unless there are no other alternatives possible, and absolutely avoid them in patients greater than 36 weeks. And this is because there's an increased risk of hemolytic anemia. Literature also divides the remaining patients into two categories. So there is uncomplicated urinary tract infection and then complicated urinary tract infection. So uncomplicated patients, this includes patients who have dysuria, urgency, frequency, and otherwise healthy non-pregnant females. That's your uncomplicated. And they're treated with cephalexin, nitrofurantoin, or Bactrim. Those are the options presented here. For a complicated urinary tract infection, this includes males. Immediately they are complicated. Patients with an obstruction, those patients who have immunosuppression, indwelling catheters, or urinary retention. If those are present, then this is considered a complicated urinary tract infection. So again, they're treated with cephalexin, although if you notice, it's for a longer duration, 7 to 10 days versus the 5 to 7 in the uncomplicated. Again, Bactrim as well, except for a little bit longer, again, for treatment. And then levofloxacin is another option for the complicated UTI. All right, so next up and last up for GU is going to be the treatment for bacterial vaginosis. BV occurs from the overgrowth of bacteria in the vagina, and it predominantly affects women of childbearing age. The most common organism that causes BV includes Gardnerella. Symptoms of this include itchiness, redness, gray to white discharge, a foul odor, and then bleeding after sex. So treatment for BV is listed here. It's metronidazole is the first one. Also clindamycin is another option to treat BV. All right, so moving on from genitourinary and on to pulmonary infections. So first up is going to be the treatment of patients with a COPD exacerbation. Common organisms for this include viruses such as RSV or influenza, or H. influenzae or Streptococcus pneumoniae are also common organisms that cause an exacerbation to occur. Cardinal symptoms of a COPD exacerbation include the following three: increased dyspnea, increased sputum volume, and increased purulence. And if those are present, then it's indicated to treat these patients with antibiotics, short-acting anticholinergic bronchodilators, and an inhaled beta-2 agonist with corticosteroids. For choosing antibiotics in this patient population, there are a variety of alternatives, and they're listed for you here. So there's azithromycin, and a couple ways to do that, doxycycline, levofloxacin, and Bactrim. So just a lot of really good options when treating these patients. So next up, of course, is going to be the treatment of community-acquired pneumonia. So common organisms for this include strep pneumoniae and then H. influenzae. Treatment for patients with no comorbidities and a low risk of failure, first line is amoxicillin, and that's 1 gram 3 times a day for 5 days. Other options are listed there, including azithromycin, dispensed as a Z-Pak, which is 500 milligrams on day 1 and then 250 on day 2 through 5. Also, doxycycline is another option available for this. For those patients who have significant comorbidities, or you have that includes diabetes, or they have a concern for treatment failure, then Augmentin, which again, of course, is the amoxicillin clavulanate, is going to be a more appropriate choice for that patient. Also, levofloxacin, the fluoroquinolone, is an option for those patients who have severe penicillin allergies. Alright, so for the last group, I will be discussing skin infections and indications for antibiotics. So there are a few definitely worth mentioning. First up is being cellulitis with and without an abscess present. So for those patients with non-purulent cellulitis, the most common organism is Streptococcus. First-line treatment for this is going to be cephalexin 500 milligrams by mouth 4 times a day for 5 to 7 days. And then if they have a severe penicillin allergy, then clindamycin is another alternative. If purulence or an abscess is present, then the most common organism is going to be Staphylococcus, and this includes MRSA. First-line treatment for this includes incision and drainage. Definitely if there's an abscess present or pus present, then you need to do an IND. If the abscess has mild drainage and the patient has no systemic symptoms of infection, then antibiotics are generally not indicated. However, if the patient has a moderate amount of drainage or systemic symptoms are present, including fever, then antibiotics are indicated. So it's going to definitely take some clinical reasoning on your end. The first-line choice for those patients with purulence is going to be the antibiotic Bactrim, as this also covers against MRSA. Next up is impetigo. So this is a highly contagious skin infection that predominantly affects infants and children. Impetigo is spread by skin-to-skin contact, and it does require treatment with an antibiotic. Common organisms for this include Staphylococcus, including MRSA again, and then group A strep. So if the lesions are isolated, topical mupirocin is going to be first-line treatment if they are isolated. However, if there are numerous lesions present, then a systemic antibiotic is indicated, first choice being cephalexin. However, remember, of course, again, if MRSA is suspected, then we go back to Bactrim. That's going to be your first-line choice for when MRSA is present. Alright, so for our final few slides, I will be discussing animal and bug bites, and then treatment for each. So frequent animal bites include bites from dogs and cats. So the common organism from a cat bite is Pasteurella, and from a dog bite is going to be Streptococcus. Indications for a prophylactic antibiotic include, and there's a lot of them, so edema or crush injury, patients who are immunocompromised, all puncture wounds, all cat bite wounds, all facial, hand, foot, or genital wounds, and then injuries that penetrate the periosteum or a joint capsule. If any of those are present within your patient, then prophylactic antibiotic is going to be indicated, and you treat them with Augmentin. And then, of course, if there are signs of infection, then you are definitely going to be treating them with the antibiotic, again being Augmentin. There are alternatives as well if you can't give that. So, for example, clindamycin is here. Also, rabies and tetanus, if they're indicated, that's really important. So that you should ask the patient if they know if the animal is up to date on their rabies vaccination. If they're unsure, then I like to err on the side of caution. They should get the series of rabies vaccine, and they're available at some emergency departments and health departments, so you might just have to call on behalf and help your patient out with that. Also, tetanus, if that's indicated. So if it's been greater than 5 years and with a wound or an injury, then we know that tetanus should be given as well. Also important to note here is that you should never close puncture wounds, as this can actually facilitate the infection to become worse. You should, however, consider primary closure for facial wounds, as this is cosmetic and this is their face. And if this is the scenario, then it's really important that you would consult something like plastics before doing anything. These next two slides are focused on treatment for tick bites and when antibiotics are going to be indicated. So indication for prophylactic treatment following a tick bite, patient without symptoms, that includes the correct tick identified. So it's the, I don't know how to say this, Ioxodes tick, or it's a deer tick. That would be the correct tick. And there's a picture there on the side, deer tick versus dog tick. Correct time. So attached for 36 hours or greater, or they actually saw an engorged tick, and it's less than 72 hours since tick removal. So it's really specific. So you're going to be asking the patient, obviously, these questions. And then correct location. So they're in a highly endemic area or an area of high prevalence, and that's the Northeast U.S., the Midwest, the Pacific Northwest. So if this is suspected, then, and they meet all those criteria, then prophylactic treatment is indicated, and the treatment is doxycycline. If patient has erythema migrans, the rash is on the left there. It's that bullseye rash. This is highly specific to a tick bite, and you would treat these patients. Again, first line being doxycycline. Rocky Mountain Spotted Fever, or RMSF. I'm not sure which is more difficult to say, but it's caused by the bite of a tick infected with Rickettsia group bacteria. So symptoms are nonspecific. They include fever, headache, malaise, myalgias, nausea, and rash. And this rash develops 2 to 4 days after the fever begins. Most cases of RMSF occur in the spring and early summer, which makes sense because this is when outdoor activity is increased. So diagnosis can rarely be confirmed or ruled out in the early phase, and therefore most patients do require empiric antibiotic therapy based on clinical judgment and location. So Rocky Mountain Spotted Fever, it occurs throughout the U.S., Canada, Mexico, Central America, and then even parts of South America. So it's really in a lot of places. However, treatment, again, for this includes doxycycline. So that makes it very easy to remember. First line for a tick bite is the doxycycline. All right, so this final slide is going to be in regards to treating lice, scabies, and pinworms. So lice, this is going to be treated with permethrin, 1% lotion. You apply it to clean and damp hair, rinse after 10 minutes, and then repeat it in 9 days. All household members should be examined, and then children can actually return to school after their first treatment. Scabies is also treated with permethrin, 5% cream. The patient applies it to their entire body, washes it off after 8 to 14 hours, and then repeat it in 1 week. You treat all close contacts, and then instruct the patient to wash all of your clothes and bedding in hot water, hot dryer, and then place it in an airtight bag for 72 hours. And then for pinworms, you treat this with albendazole, and you repeat in 2 weeks. There are some other options here, and you should also consider treating the other household members based on if they're symptomatic and your clinical judgment. All right, so that's going to be it for today's discussion. Hopefully you leave here knowing something I suppose you didn't know before. The next video I'm going to be doing is going to be that Q&A. I mentioned it, so if you do have any questions for me, personal or professional, go ahead and leave them down below. Perhaps I will answer them. As always, don't forget to like the video and subscribe to the channel. And until next time, I wish you all the very best, and I'll talk to you soon.